بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل عام وأنتم بخير ورمضان كريم على الجميع. Good evening everyone. My name is Mustafa Al-Shahni from Iraqi Stroke Network team. Today we start our fifth educational webinar with extraordinary speaker talking about a hot topic. Now I leave the word to our panelist, Dr. Dilan Kurda. Dr. Dilan is a well-known neurointerventionist in Iraq and Kurdistan region. The word is yours, Dr. Dilan.
Thank you, Dr. Mustafa, for the presentation and for arranging and organizing this scientific activity. And I welcome Dr. Mohammed to present this talk about the role of TENECTEPLASE. I remember when the positive trials of mechanical thrombectomy came out, and we in Australia used to give Alteplase as standard of care, and in a lot of centers in the world it's a standard of care still. And recently there has been a shift and a lot of talk about TENECTEPLASE and its role and increasing a role in acute ischemic stroke. So today I'm personally hoping, and I think it's that the thing is the same for the rest of the neurologist attending this activity, is to know what's the benefit of TENECTEPLASE over the standard of care in achieving recanalization with or without mechanical thrombectomy, and talking about modified Rankin score in 90 days, which is a functional outcome in 90 days, as well as, and importantly as well, rate of symptomatic intracranial hemorrhage after TENECTEPLASE compared to Alteplase. So the mic is yours, Dr. Mohammed, and feel free to have the time. Don't restrict yourself with the 45 minutes or 50 minutes.
Okay, thank you, Dr. Dilan. Just we have some addition. Thank you, Dr. Dilan, for this talk. The Q&A section will be led by Dr. Baraa, also from our team. So, Baraa, please go on.
Hello, all. I'm Baraa, a junior doctor in the second year and also interested in neurology. I'll be responsible for the Q&A section at the very end of the lecture. So feel free to write down any ideas or questions, as we are going to discuss them all at the very end. Thank you.
Thank you, Baraa. And before we go on, we would like to remember all the attendees to, as Baraa said, write down their questions. And if one wanted to intervene with Dr. Mohammed, he told me in person he doesn't mind if one intervene through his talk. Our guest today is Dr. Mohammed Almekhlafi. Dr. Mohammed is a neurologist and a clinician scientist at Calgary Stroke Program. In addition to his training in stroke and interventional neuroradiology, he holds a master's degree in clinical epidemiology. Throughout his career, Dr. Almekhlafi has been driven by a passion for finding innovative solutions to the challenges faced by the patient with cerebrovascular disorders. He is also actively involved in the teaching and mentoring the next generation of neurologists and stroke researchers. He has published numerous papers in top-tier medical journals and presented his work at conferences worldwide. And the final one, I think it was named Go Global, sir, at the last meeting. Okay, so we would like to greet Dr. Mohammed deeply and welcome him, although in Iraq, although via internet. The word is yours, Dr. Mohammed, please.
شكرا جزيلا. رمضان كريم للجميع. Thank you very much for the kind introduction, Dr. Mustafa and Dr. Kurda. And hopefully everyone will find this talk relevant. And before I kind of prepare the slides, I've asked Dr. Mustafa about the attendees and audience, and he told me that there will be a good number of aspiring neurologists and trainees who will be attending. So part of the talk might be a bit basic, but I'll try to keep it relevant to everyone so that we don't lose interest from all the audience. These are my disclosures. Most of my fundings come from the Canadian Institute of Health Research, and I don't have any direct industry funding. So yeah, so this is the outline of my talk. I'll be talking about thrombolysis in stroke, the status as it is, and why there was a need for an alternative for TPA alteplase. After that, I'll talk about the evidence for TENECTEPLASE and recent thrombolysis trials that discussed its use in patients who are going for endovascular thrombectomy, but also in patients who are not candidate for thrombectomy. And finally, I'll touch on what the current guidelines say about the use of TENECTEPLASE versus alteplase, and what are the future direction for using thrombolysis in various patients population, including those who are candidates for EVT as well, endovascular thrombectomy. A few words about the Calgary Stroke Program. This is a program where I trained and practiced. I'm originally من مكة المكرمة من المملكة العربية السعودية. I did my training and I'm currently working at the Calgary Stroke Program. The Calgary Stroke Program is located in the province of Alberta in Canada. The program has pioneered a number of innovations in the world of stroke, including the aspect score was developed at the Calgary Stroke Program. The recent ACT trial that compared alteplase with TENECTEPLASE was led by the Calgary Stroke Program. And finally, the ESCAPE trial for endovascular thrombectomy and the Hermes collaboration were both led by the Calgary Stroke Program. So thrombolysis is not a recent concept that only started in 1996. It has come to the front at that time when the FDA approved it following the NINDS trial in 1996. But the use of thrombolysis in stroke dates back almost 60 years before that, when streptokinase and then urokinase were discovered and used in stroke patients. And the first urokinase trial was actually in 1986, so almost 10 years before the NINDS trial. And this just shows you how long it took the medical field to find the correct patient population. Initially, people thought all stroke comers, obviously neuroimaging was not as developed as it is right now, or even in the 90s, back in the 80s or in the 50s. And because of that, there was limited access to CT, so thrombolysis was given to patients with ischemic and hemorrhagic stroke initially. And then people realized that it's not a good idea to give it with people with hemorrhagic stroke, so ischemic stroke. And then we started to kind of zero in on the patient population that would benefit the most from IV thrombolysis until the NINDS trial found a niche patient population. And then obviously the indications has expanded, and obviously the use of agents other than alteplase has come to the front as well. And ischemic stroke, we currently have a few evidence-based treatments. So 1996 was the IV alteplase, TPA. But even before that, the benefit of admitting patients to stroke unit, a dedicated physical space where they can be treated, looked after by nurses who only deal with stroke patients, looked after by rehab team who are expert in managing or rehabilitating stroke. And then as Dr. Kurda alluded to, endovascular thrombectomy, it came to the front in 2015 when the trials, 4 or 5 trials were positive for endovascular thrombectomy with an astonishing number needed to treat. So these are currently in acute ischemic stroke, what is proven to help and to reduce disability. And one concept that is shared by all stroke trials and all these intervention is the importance of time, importance of speed. Every time in stroke matters. Patients who have a 1-minute delay on average will have about 2 million neurons lost. If we saved 1 minute to these patients, it is almost equivalent to gifting them 2 days of healthy living, of independent living. 15 minutes saved is equal to saving a 1 month of healthy living, while a 1 hour of delay cost them about 3.5 years of equivalent neuronal loss to normal aging. So time and recognition, treatment, workflow are all important concepts that are kind of developed over the years, the importance of these ones. And this is a meta-analysis of a few IV thrombolysis randomized trials showing that So on the y-axis here, we have the odds ratio, the likelihood of improvement measured by the modified Rankin scale. I'll talk a little bit later about the modified Rankin scale, but the scale of 0 to 1 means excellent recovery. Patient either has no symptoms of stroke or have some symptoms but no disability. And the x-axis is the treatment delay in hours. And as you can see, the best odds of recovery, the best likelihood is patients who are treated within obviously 1 hour, which is very few patients. But as the time delay increases, the likelihood of benefit decreases until roughly about 5 hours, where the confidence interval reaches 1, and 1 is the null value in the odds ratio, meaning that there is no benefit or risk. So it reaches 1 at about 5 hours. So there is benefit, but if you save an hour, if you shift this patient by half an hour and you treated them here instead of here, you have gifted them, you've provided them with higher likelihood of recovery. And the same applies to clot. This is a study, a Korean study, where they looked at the likelihood of recanalization with only IV thrombolysis. And they found that patients who received treatment within 60 minutes from onset time, they had almost a third of them had almost complete recanalization. And the likelihood of recanalization with IV TPA decreased with time. And obviously, these are relatively distal clots, not amenable for endovascular thrombectomy. And so that's explained why a third had recanalization and treated early. But it also stressed that clot does change with time. It's not only we're losing brain tissue by delay, but the clot is changing and becoming more organized, more resistant to thrombolysis, which makes it harder to open just with IV thrombolysis. But it is not easy to save time in treating stroke, because there is a number of steps that need to be well organized, well kind of maintained over time, and people trained to kind of go through them with a stroke patient from the time of detection that stroke symptoms are detected until the medical system is alerted and the patient is delivered to the hospital, whether with ambulance or taken in by family. And then inside the emergency department, when they check in, the clinical assessment, lab, imaging assessment, until the decision is made to give IV thrombolysis or perform endovascular thrombectomy. So all these steps are complex, multiple people are involved, and a delay in one will impact all the rest. And that is the importance of realizing these components and addressing each one of them individually. This is currently what the American Stroke Guidelines recommend in terms of door to treatment time. So from the time the stroke patient arrived to the emergency door until the needle time, the time that the treatment is started. So within 10 minutes, they advise that the medical assessment is done. Within 15 minutes, the stroke team should be available and aware. Within 25 minutes from arrival to emergency, a CT scan should be done. And then it gives you another 45 minutes, which is lots of time until treatment is given. And because of that, right now, many people are actually calling for a door to needle time of less than 30 minutes. And that is the benchmark that currently used, at least in the province of Alberta here, is a door to needle time of 30 minutes for treatment for patient with acute ischemic stroke. But as you can see, that these are all steps that require multiple people from emergency, from neurology, from diagnostic imaging until the treatment is given. This is just one study I wanted to show you from Helsinki, Finland, where they started to look at their door to needle time and how much delay has occurred. And this is the y-axis, the number of patients treated, and this is the year. And the chart bars, or the bars over here, represent how many patients were treated more than 3 hours from onset versus less than 3 hours from onset, the blue bars. And the line is the door to needle time. So as you can see here, so the door to needle time when they started in 98 was over 100 minutes. And then over time, obviously change doesn't happen overnight, but over time they were consistently able to drop the door to needle time until currently it's astonishingly lies below 30 minutes, so about 20 minutes of door to needle time. And this is impressive. Like even in excellent centers, this number is not achievable, but it's a system matter. If the system is aligned, if everything is in place, this number can be achieved And in this reference, which I invite you to have a look at, they describe what process and what changes they've made in order to achieve this change over time. But as you can see, it took a decade or more than a decade to reach that. I'll just briefly talk to you about our current workflow in Calgary for IV thrombolysis and thrombectomy for all suspected acute stroke. So typically here, the ambulance system, the EMS, will be the ones dispatched or called regarding a possible stroke once they arrive to the location and identify that the patient had a stroke, using whether the FAST acronym, the face, arm, speech, and time, or using the LAM score, kind of assessing basic motor functions. They will notify the one hospital that is dealing with the stroke in Calgary and pre-notify them that they have a stroke patients within the treatment window, within 4.5 hours, or even right now, the window is 24 hours for patient with disabling deficit. And this pre-notification will go to the emergency department, to the neurologist, and to the imaging team as well, to the CT scan department. Once the patient arrived to the hospital, everyone, at least the neurology team, will be waiting in the emergency department. A rapid assessment will be done, just a quick NIHSS, make sure that the patient is vitally stable, there is no airway compromise. We typically don't do an ECG or chest X-ray before the CT scan. Patient, we just put an 18 gauge needle, withdraw the blood, and the patient will stay on the ambulance bed and get transferred to the CT for imaging. At that time, the stroke protocol is a simple CT and multi-phase CT angiogram. So there is no CT perfusion except in few cases. Typically, we don't wait for creatinine unless the patient or their family indicate that the patient has something urgent. But most of the time in stroke, hardly ever actually, that we would wait for creatinine before performing CT angiogram. And then the stroke team, as the imaging being done, and that's the concept of parallel processing, that one step is happening while something else is happening in parallel. So as the CT is being done, the stroke team will gather more information about the onset time, whether it was witnessed or not, what medications patient is taking, blood thinners obviously is the main ones, and so forth. And then once the scan is done, the patient will be in the CT bay area. So in the imaging department still, we'll go over the CT scan, and then a decision to treat will be made. Typically, we don't wait for the report of the CT to come. Part of the training of trainees is to be able to interpret acute CT and CT angiogram, looking for early ischemic changes, looking for hemorrhages, whether subdural, intracranial, or even small intraventricular that could sometimes be hard to detect. And then the INR, we would wait for the INR only if there is suspicion that it'll be abnormal. So if the patient was on warfarin and so forth. Other than that, if the stroke is disabling, if the patient is within the window, the blood pressure is okay, most of the time we'll give thrombolysis next to the CT area, or at least in the emergency department before the patient is taken to the observation area. And as I said, parallel processing is important, but these are typically the step for thrombolysis. And I won't be going into details, but these are two of the new advances, relatively new, that made treatment in other centers, in non-comprehensive stroke centers possible. So centers that only have emergency physicians, for example, is the use of telemedicine. So basically just to look at the images to see the patient if they have availability for CT. But obviously, if they don't have a CT scan, then the patient need to be transferred to the nearest hospital with a CT, where this telemedicine consultation can happen, and then IV thrombolysis can be given in that center. And the other kind of still emerging is the mobile stroke unit. So it's basically a mobile CT scanner with a physician or a telemedicine capabilities on board, where they will be dispatched if there is a suspicion of an acute stroke that seems that patient is having clear stroke symptoms, and they will image the patient. If they confirm that it's symptoms of stroke, there is no bleeding on the CT, they will give IV thrombolytic inside the truck. They have point of care, meaning just a mobile small lab to check for INR, to check for platelet if there is an indication. But and some of them, the CT scan has a CT angiogram built in as well, just to help where the patient would go for thrombectomy. if needed. But these are two of the things that are even enabling faster treatment, whether in centers that don't have neurologists on sites or at the patient as on street or on way to the hospital. And Alteplase has been working fairly well until people more and so, and that's largely driven by the advances in the cardiology field. That cardiology started with Alteplase and then switched to TENECTEPLASE. And people kind of started to wonder, why don't stroke kind of make a similar switch? One reason is that Alteplase is a 1 hour infusion, so there's pump required, there's supervision required during infusion. There are possibilities of error in dosing, especially if it's a small center that's not used to using Alteplase. And we've had few people saying, oh, we wish you guys give TENECTEPLASE for stroke. We are more used to giving TNK with MI and STEMIs and so forth. So why is stroke still using Alteplase? And so all these, and obviously cost in certain places, the cost is almost double for Alteplase versus TENECTEPLASE. All these issues kind of made scientists and researchers start to wonder about the use of TENECTEPLASE. And TENECTEPLASE is an analogous to Alteplase. The two molecules look fairly similar, except in 3 amino acid location. But this change has given TENECTEPLASE higher fibrin specificity than Alteplase. And also it made it more resistant to plasminogen activator inhibitors, which made the half-life longer, and so more time to act on the clot theoretically. And these reasons, in addition that TENECTEPLASE is given as just a one bolus injection, TENECTEPLASE is widely available because it's given for MI as well. All these kind of stimulated the research for looking at TENECTEPLASE as an alternative to Alteplase. Obviously, there is some evidence, and I'll go some of these studies, that TENECTEPLASE may offer better recanalization and safety profile than Alteplase as well. So the very early study started in 2005, so almost 20 years ago now, where it was a dose finding difficulty. So Dr. Haley and his colleague in Virginia looked at various doses, so 4 doses of TENECTEPLASE, all weight-based, so 0.1 milligram per kg, 0.25, 0.4, and 0.5. And eventually they discovered that the 0.5 had higher hemorrhagic complication, and it was dropped very quickly. And the 0.1 was still kind of showed some benefit, but there was no increased risk. And with that, kind of they moved to a phase 2 that they wanted to test the 0.1 versus 2.5 versus 0.4, but that didn't unfortunately come to fruition, and the study was stopped early. And it wasn't until the group in Australia with the Extend-IA TNK published their study comparing TENECTEPLASE versus Alteplase. And I'll be making in the top right corner, I'll be making kind of some kind of summary notes of the findings of the studies. But this is, at least here, the study was 0.25 milligram per kg TNK versus the standard dose Alteplase in patients who are going for IV, for EVT, prior to the EVT. And they discovered, so the outcome was the reperfusion on imaging. So those are patients who are going to receive EVT. So the outcome was how many of those patients on the first images of the angiography that was obtained, how many of them achieved successful reperfusion or recanalization defined by the TICI score. And they discovered that almost more than double the patient, 22% of those who received Alteplase versus 10% who received TENECTEPLASE achieved reperfusion. And this met the non-inferiority as well as the superiority margin. And this is the modified Rankin scale. These stacked bars basically represent each strata. So the modified Rankin scale is a functional outcome score for stroke. So a scale of 0 means that the patient has no stroke symptoms and no disability. And a scale of 6 is death. Basically, 5 is severe disability, that the patient is bedridden. 4 is major disability, that they need constant help. 3 is moderate disability, that they need assistance to walk with a cane or a walker. 2 means that the patient had recovered from stroke, but they have some disability, but they are still independent with mobility and with their activity of daily living. A score of 1 means the patient has some stroke symptoms, but no disability whatsoever. And the score of 0 means, as I said, no symptoms and no disability. And as you can see here, TENECTEPLASE was superior to ALTEPLASE in terms of 0 to 2, not only being non-inferior, but actually superior to ALTEPLASE. And that was a huge landmark study, small study, 200 patients, but still very encouraging for TENECTEPLASE compared to ALTEPLASE. It was followed by EXTEND-IA TNK2, so similar concept, but in patients who are going to EVT, similar design, looking for reperfusion, looking for modified Rankin scale. But the main thing is they compared TNK 2 doses, 0.25 and 0.4. And this time there was no difference between the 2 doses. So 0.25 was similar to 0.4. There was no increased hemorrhages, no advantage in terms of reperfusion. And because of that, the 0.25 seemed to be the correct dose, or at least the sufficient dose for patients who are going for EVT. At that time, kind of the people started to look at more indications. So not only patients who are going for EVT, we want to treat all stroke patients with TENECTEPLASE. And since there were some studies done at the 0.4 milligrams, so this is a slightly higher dose than the kind of Haley were suggesting, but still 0.4 seemed to be a reasonable choice, and they compared it to 0.9, the usual dose for ALTEPLASE, but they treated all stroke patients, and there was the study couldn't meet its intended outcome. The study wanted to assess whether the 2 doses were comparable, and unfortunately, the conclusion from the study that there was ALTEPLASE might have been slightly better, although non-significant, but TENECTEPLASE was not non-inferior. So the 2 were not comparable. So it was a negative study. And when people started to look at why, some of the reasons that the 2, one of the main criticism is the median NIHSS, so the stroke severity for patients who were treated the median was 4. Meaning that those are mild strokes. Many centers may not even treated them, and possibly some of them may have not had a stroke. With an NIHSS of 4, with perhaps some dysarthria or some sensory symptoms, it may not have been a stroke to start with, and that could explain why some patients, the two medications didn't seem to achieve much benefit for both of them. And then they followed it. They wanted to replicate EXTEND-IA TNK, but at that time they took the 0.4, so same 0.4 dose as EXTEND-IA TNK and NOR test. They compared it to ALTEPLASE in patients who were candidate for endovascular thrombectomy. And so this is NOR test 2, and unfortunately the trial was stopped early because increased harm in patients who received the 0.4 milligram per kilogram of TENECTEPLASE. And with that, the study almost enrolled 200 patients at that point when it was stopped, and they didn't go any further. There was increased mortality and lower likelihood of benefit with the TNK 0.4. So that was kind of the end of patients who were going for TENECTEPLASE versus ALTEPLASE or TENECTEPLASE prior to EVT. That was the last trial. The remaining trial I'm going to show you are for all comers with stroke. So this is the ACT trial that included 1,500 patients, all patients coming with stroke symptoms within 4.5-hour window. And it was a non-inferiority trial. So basically they wanted to assess whether ALTEPLASE or TNK is non-inferior or comparable to ALTEPLASE at this dose. And at that time, as you can see from the modified Rankin scale, the 0 to 2, the 2 treatments were almost comparable, while in the 0 to 1, TENECTEPLASE might have been slightly better, but this was not superior. However, the trial met its outcome, and non-inferiority threshold was met, meaning that we concluded that TNK is non-inferior to ALTEPLASE. So this was the major trial that showed that for all stroke patients, you could either treat with TENECTEPLASE or ALTEPLASE. Shortly after, in October of last year, the UK trial ATTEST-2 was presented. It hasn't been published yet, but it was presented in the World Stroke Congress. Similar design to ACT trial, so all patients coming with stroke symptoms, once a stroke an ischemic stroke is confirmed on CT scan, meaning that there was no hemorrhage, patients were randomized to Alteplase versus TENECTEPLASE, and then they collected the outcome. And the trial showed that almost similar result, that 0 to 2, slightly better with TENECTEPLASE, as well as 0 to 1. But overall, the two were equivalent. The superiority was not significant, but TENECTEPLASE was not inferior to Alteplase. So, and this again was another large trial of over 1,000 patients. And these two trials, ATTEST-2 and ACT, are the two main trials that support now the use of TNK in all comers with acute ischemic stroke. The last trial that used TENECTEPLASE was the ATTEST-2 trial, which looked at 0.25 milligram of TNK versus placebo. So this wasn't in comparison with Alteplase, but in patients who presented in the late time window and had a perfusion defect. So all those patients had perfusion imaging done, and then the trial was about 500 patients when it was stopped for futility because there was no significant difference between placebo or TENECTEPLASE. The good news is there was no increased mortality, no increased harm by the use of TENECTEPLASE, but it was not helpful as well. And because of that, currently we don't advocate for the use of TENECTEPLASE in the late time window. But the study hasn't been published yet, so we'll have to see the entire result. So just to summarize these trials for TENECTEPLASE, so IV TNK with a 0.25 milligram is the dose to be used. It was found superior to Alteplase in patients who are going for endovascular thrombectomy, meaning that better outcome and also better reperfusion. 0.25 is not inferior to Alteplase in all stroke comers, so you could choose either TENECTEPLASE or Alteplase, whatever is available in your center. The 0.4 milligram is more harmful in patients who are going to EVT, and the 0.25 was not found to be helpful or more superior to placebo in patients in the late time window. So yeah, so the 0.25 was the main dose, and with that, the few guidelines have changed. For example, the Canadian Best Stroke Practice Guidelines nowadays recommend TENECTEPLASE as an alternative to Alteplase among stroke patients within the 4.5 hours. And the dose recommended is 0.25 milligram as a bolus over 5 seconds. Similarly, the European Stroke Guidelines says that TENECTEPLASE can be considered as an alternative in all eligible patients. It is as safe and as effective to Alteplase. And they basically kind of mentioned that the patients, it should be given obviously as a single bolus, and the expert consensus, so not the evidence base, the expert consensus is that actually TENECTEPLASE is more favorable to Alteplase just because of its short administration time, as well as there is no need for infusion and the possible better reperfusion. The American Stroke Guidelines hasn't been revised yet, but the American guidelines actually recommend the use of TENECTEPLASE over Alteplase in patients who are going for thrombectomy. So if a patient has large vessel occlusion, then perhaps TENECTEPLASE is better, and that's mainly based on the Extend-IA TNK trial. So what is next nowadays? So I mean, one thing that hasn't been really well done is whether the dose of 0.25 is sufficient, or should we even lower the dose? As I showed you in the Haley studies, early studies in 2005, he tested a dose of 0.1, and that was not associated with any safety concern, but it hasn't been really tested in any of the trials that I presented to you. So whether a lower dose will have even better safety, the Enchanted trial that was done for Alteplase compared a standard dose of 0.9 versus a 0.6 milligram. And at that time, it couldn't find or couldn't conclude that 0.6 is equivalent, but there was clearly lower mortality and less hemorrhagic symptomatic hemorrhages with the low dose alteplase. Whether the same will be with tenecteplase is not known, and that's something that could possibly be explored. And then in the last year, there has been a number of reports that showed that patients who are taking the DOAC or NOAC anticoagulants benefit from thrombolysis. So traditionally, people who are on warfarin with an INR of 1.7 or more, we have excluded them from IV thrombolysis. But DOAC or NOACs, we don't have a blood test to check for them, at least available readily. And some of those patients took the dose more than 12 hours. And still, current guidelines say if a patient has taken the dose more than 48 hours, they should be okay. But within 48 hours, we have excluded those patients from treatment. While these studies suggest that you may actually be able to give it safely up to 12 hours or so from the time of administration. So that's another kind of patient population. And then obviously, patients who are undergoing AVT or endovascular thrombectomy. So if a patient arrived to your hospital and you have access to thrombectomy, do you need to give IV thrombolysis before or not? There has been a number of studies that looked at that, and current evidence says if a patient meets the criteria for IV thrombolysis, you should give IV thrombolysis before thrombectomy. But obviously, on a practical standpoint, there might be some limitations, either related to availability or cost or both, that may limit the use of IV thrombolysis before thrombectomy. But that's still, with tenecteplase, we don't know whether it's the same situation or not. And to answer this question, I know Dr. Mustafa mentioned about ACT Global. I have just 2 slides about ACT Global, that the traditional trials, as I showed you with ACT or ATTEST or Extend IA, these are trials that are kind of enrolling patient independent from one another, and they take many years to conduct. And obviously the cost with setting the infrastructure for each trial is large. And because of that, and especially during the COVID time, the concept of platform trials has emerged, in which the same patient population will be kind of allocated to interventions. And during COVID, this was, for example, steroids or intubation and so forth. So they will be allocated to same intervention. And then as our understanding evolves, so after, for example, 200 patients, we know that treatment X does not work. That treatment get dropped, but the trial continues with addition of another intervention and so forth, so that the trial is evolving. As long as the same inclusion criteria applies to that group of patients, then those patients could possibly be within the same trial. And so that platform trial is what the ACT Global initiative, led by my colleague Joy Menon here at the Calgary Stroke Program, together with Dr. Craig Anderson in Australia at the George Institute, they are kind of co-leading this initiative for acute stroke platform trial, where the same patients, where patients will be kind of randomized to whether receiving low dose tenecteplase or blood pressure lowering or intra-arterial tenecteplase, depending on the eligibility and so forth. But the trial will have multiple interventions. The same patients could be in 1 or 2 interventions, depending, and we will test for interaction between these treatments at the end. But it is a global initiative, meaning that we are hoping that it will include many centers, and hopefully all capable centers around the globe, and hopefully we'll have a center in Iraq that can participate and take part, even with one question. It doesn't need to be all the intervention. This platform has number of intervention, and maybe only one intervention is applicable in your setting, and that might be the one that the platform starts with. But more regarding this, the platform is in the work. We're hoping to start sometime in the next few months, and then hopefully expand. And you'll hear more about it in the World Stroke Congress if you're hopefully coming in October in Abu Dhabi to attend. Before I conclude, I prepared just few slides about one kind of, this is a very, I'd say, a landmark paper for IV thrombolysis, that it's a number of experts met, and they went over the criteria of the NENS trial, inclusion and exclusion, because these are the current inclusion and exclusion criteria that we have been using since 1996. And they revised the exclusion criteria just to say which is an absolute contraindication and which ones are the relative contraindications. So I advise you to look up this paper if possible, please, and read it. It's an enjoyable paper, but one of the kind of criterias or things that they talked about first was whether age should be an exclusion, and they summarized this is one of the kind of summary kind of slides from a meta-analysis for IV thrombolysis trial showing that patients, so this is a forest plot, basically patients less than 80, more than 80, and the size of the box means how many patients were in that strata or that, and so as you can see here, there's almost 2,000 patients here versus the ones above 80, there was almost close to 1,500, but or actually 5,000, I should say, in those, and versus 2,000. And when an intervention is on this side, it means that giving Alteplase or TPA is better, while it's worse over here, and the line is the 95 confidence interval. So for age, at least you can see that patients whether younger than 80 or older than 80, you could still achieve benefit in the right, obviously, right patient population, if the patient was previously independent, if they are relatively healthy, as opposed, obviously, to someone who might be already going through dementia or already bedridden and so forth. So there is obviously restrictions, but overall, if all are equal between the two patients, age shouldn't be a deciding, or at least shouldn't be an excluding factor for IV thrombolysis. What would be factors that increase the risk of hemorrhages? One of them, an important one, is systolic blood pressure. So the higher the systolic blood pressure, up to a maximum of 180, the higher the likelihood of symptomatic hemorrhages after thrombolysis. And obviously, high hyperglycemia is also a risk factor that current studies do not advocate for giving IV insulin or lowering the blood glucose before, but at least you would recognize that this is a patient who might be at a high risk of bleeding with IV thrombolysis. And just that the hemorrhage as kind of just as a summary or a review for what we mean by hemorrhage after stroke, there is a SITSMOS classification for hemorrhages. So there is some what is called hemorrhagic infarction, HI1, which is areas of hyperdensity within the infarct, small areas, no mass effect, no kind of localized confluent area of bleeding. So that's HI1, and that mostly asymptomatic and is expected sometimes with reperfusion. So it's not uncommon to see it. And even HI2. HI2 is slightly bigger than HI1. So there is the petechia of the tissue with the hemorrhage is larger, but again, there is no mass effect, and that's within the area of infarct as well. We move to the more symptomatic and more dangerous bleed when we talk about parenchymal hemorrhage. So these are homogeneous area of bleeding. It's PH1 if there is some mass effect, but the bleeding is relatively small, less than 30%, less than a third of the entire infarcted area. And obviously the PH2 is the dangerous and most likely symptomatic hemorrhages when it's a big hemorrhage with mass effect and more than 1/3 of the area of infarct. So as you can see here, the midline shift and the large area of the bleeding. So these are classification. Typically, I would say that most of symptomatic hemorrhages fall within the parenchymal hemorrhage 2, PH2, but definitely some of them might be PH1. And obviously that definition or saying symptomatic depends on reperfusion status. So if the patient has reperfused and they started to improve, and then a bleeding happens and they worsen, you know that it is symptomatic. But unfortunately, if reperfusion was non-successful already, it was too late, then the patient is already in HSS of 15 or 20. So a small bleeding or even a large bleeding may not worsen them much compared to what you expect with an evolving large stroke. And these are the risks from large pooled analysis of IV thrombolysis trials. So 5.4% for hemorrhagic infarction type 1, 4% for 2, and thankfully less than 3% for PH1 and PH2. But overall, they constitute about 6% risk of hemorrhages. With tenecteplase, the risk is about 3% in all the trials. So ACT trial for all comers with stroke. 3% in the ACT trial, 3% in the ATTEST, and even less than 3% in the NORTEST 1 trial. So tenecteplase is reasonably safe, but at least what we know from ACT and ATTEST, it is not a high risk of hemorrhage, but there is a suggestion that it might be lower risk compared to alteplase. Stroke severity at baseline. So the worse the stroke severity, there is a notion that the higher the risk of bleeding, and that is reasonable with only IV alteplase. So a patient who come with NIHSS of 16 or 21, this again a forest plot showing that there is which is better, alteplase versus no alteplase among those patients with variable NIHSS scores. As we can see here, patient with NIHSS, high NIHSS do better with alteplase or IV thrombolysis. But typically those patients are the ones who have a large vessel occlusion, LVO, and therefore EVT is probably was done in conjunction with IV thrombolysis, and that explains why. If those patients didn't go for EVT, I don't think you'd necessarily see much improvement with alteplase, just because if they have a large vessel occlusion, the likelihood of reperfusion is relatively low. And this one shows that those patients also do have high risk of hemorrhage if they didn't go to endovascular thrombectomy to reperfuse. And finally, kind of the aspect score, I alluded to it. So it is a systematic way to assess early ischemic changes on CT scan. I wouldn't go over the details of the score, but basically a normal scan will have a score of 10 out of 10. And the complete wipeout MCA will have a score of 0 out of 10. So each region affected takes 1 from the score. And so in this study, we saw the investigators have shown that the higher the aspects, meaning the more more limited or the minimal changes on the CT scan, the higher the likelihood or probability of excellent outcome, and the likelihood decreases as there are more and more changes on the CT scan. So that's another thing to factor in with the IV thrombolysis, is how bad is the early ischemic changes in the CT scan and so forth. And then finally, kind of whether patients without occlusion benefit or not. If sometimes people have kind of moderate stroke symptom, a CT angiogram is done and there is no occlusion. And this meta-analysis does show that compared to controls, patients who don't have a clear occlusion in the CT angiogram do better. And I suspect most of those patients may have an embolic shower. So there are clots that are scattered, but they are relatively small in size. We just can't appreciate them or can't see them because they are too distal. And some of them may have lacunar stroke, small vessel stroke, and those ones I'm not clearly sure whether IV thrombolysis help, but I think it's, if there is no access to CT angiogram, I definitely treat patients based on CT scan of the head as long as it does seem like a disabling stroke. So again, please have a look at this paper. This is kind of what they defined as relative contraindication, meaning it is a case by case and depends on your practice and your judgment. There are still some absolute contraindications that no one disagree on, but there are gray areas that people can use. And I like this summary table by Dr. Andrew Demchuk, who's the director of the Calgary Stroke Program. So he kind of spot these as a spectrum. So time of onset, if a stroke patient comes less than 90 minutes, then that's definitely a treat for IV thrombolysis. Even the recent IRIS meta-analysis for the thrombolysis before thrombectomy showed that the earlier patients who present with large vessel occlusion, the more likely that thrombolysis plus EVT would be helpful as opposed to thrombectomy alone. And then the benefit as they move away from this time of 90 minutes, the more probability of harm increases. For age, treat all ages. Blood glucose, patients with normal or even slightly high glucose do benefit. Patients with very high hyperglycemia might not be considered for IV thrombolysis. And again, these are kind of just broad recommendations, but case-by-case interpretation is necessary. NIHSS, patients who have no disabling symptoms. So NIHSS less of 5. Currently, there is no evidence that IV thrombolysis help. If anything, it actually might be harmful. INR, obviously, if patients are on anticoagulants. White matter changes, none versus severe white matter, early ischemic, not early ischemic, but small vessel ischemic changes. Aspects, the better the aspects, the more kind of likely that patient will benefit with little harm. And then occlusion location, the more proximal occlusion or the medium occlusion, the more likely they will benefit. But patients with no occlusion is, I'd still advise for treatment, especially if you don't have access to CT angiogram. But if patients have lacunar infarct, the benefit is not very clear. But again, there is no benefit that those patients will have more harm. And with that, I thank you very much for your attention and bearing with me over these kind of slides. And hopefully kind of I provided you with an overview about TENECTEPLASE trials, the importance that time is brain, and to look for reasons to treat patients and to improve their management. This is my email. If you have any questions that we don't get right now, please feel free to reach me at any time. Thank you very much.
Thank you very much, sir. Thank you for this comprehensive review about TNK. Now we move to our panelist, Dr. Kurda. Do you have any comments?
Thank you very much, Mustafa. Thank you very much, Dr. Almekhlafi, for the extremely comprehensive TENECTEPLASE talk, and we can say also some outline and brief talk about acute ischemic stroke, in especially LVO. I forgot to tell you, I am raised and trained in Australia, and I still remember when all this fuss in Royal Melbourne Hospital, at the Austin, Monash Hospital, all these centers in Melbourne, they were talking about TENECTEPLASE, let's go to TENECTEPLASE, and clearly we could see it's going to be positive trials that we were doing. And then I'm glad I was talking a few days ago, I mean last week I was in Baghdad, and I was just talking to the neurologist there, that I was like telling them we need to switch to TENECTEPLASE, not only because of these talks and all this as well. Cost is an important aspect in this, and time is very important. It was funny, one of the neurologists mentioned something that was a bit weird for me. He said the only problem that he's not inclined to use TENECTEPLASE is the fact TENECTEPLASE can be given very quickly. And I said, and what's wrong with that? And he said, because I try to look for reasons not to give the thrombolysis. So with with Altiplase, I have some time, and in between I'll find some potential contraindication that it will make me stop the infusion. But in case of TENECTEPLASE, I won't have that time. That's just a side comment, but aside from that, I again thank you very much, and I don't think I have anything to add after this comprehensive review, and hopefully you can stay with us in this newly born society for ongoing academic sessions and potential meetings in the future, which will be face-to-face, hopefully. Thank you.
Thanks, Dr. Kurda.
Thank you very much, sir. Now we move to the Q&A section, and Dr. Baraa, and before that, anyone from the attendees, if he want to share his voice, please raise a hand. So now, Dr. Baraa, tell us what questions you have gathered.
There are a few questions came in the inbox. Number one, does TNK carry any superiority for large vessel occlusion strokes? And does the literature recommend using it in such cases, especially in our setting where mechanical thrombectomy is not commonly available?
Yeah, so the Extend IA-TNK1 trial showed that 0.25 milligram per kg TENECTEPLASE is superior to Altiplase in terms of reperfusion or recanalization. And so I'd say yes, definitely there is evidence that it is superior, but at least from the rest of the trial, ACT and ATTEST, it shows that it is equivalent to Alteplase. I do think personally, from my personal kind of observation, that TENECTEPLASE does have better reperfusion than Alteplase. So I think whenever possible, the main thing, and just that is one thing to follow on Dr. Kurda's comment, that nurses and emergency physician, they love TENECTEPLASE and the switch to TENECTEPLASE because they're used to it, at least in MI. But the dose that used in MI is 0.5 milligrams. So it's double the dose for TENECTEPLASE in stroke. So that's just the one caveat to please be careful with, that it is half of the dose, half of the cardiac dose, and 0.25 milligram. But definitely for patient with LVO, whether they will be going to EVT or not, I would advise use TENECTEPLASE. And currently the guidelines, the European and the Canadian guidelines support that as well.
Okay, Dr. Hussam have some questions.
Okay.
Please go.
Good evening, everyone. Thank you for the comprehensive, nice lecture. I have like a question about the FDA and EMA approval of TENECTEPLASE. You know, the regulations of Ministry of Health in Iraq will not allow us to use any drug unless it is approved by the FDA and the EMA as an indication. So as far as I know, until now, the FDA and EMA have not yet approved TENECTEPLASE for the use in stroke. Would you expect, when you expect that there will be an approval of using TENECTEPLASE in acute stroke by the FDA and the EMA rules?
So as far as I know, Dr. Hussam, and thank you very much for your question, that the European has already approved it. So it's getting in on the label, so of TNK, that it is. The TNK has been approved. Let me just try to post the link. So yeah, so it is, EMA has approved it for TENECTEPLASE for you. So you can go ahead and please use it if possible, or at least apply to the Ministry of Health to amend its use. But it's still ongoing. The discussions, I was just talking with my colleague Bijoy Menon, who's kind of was the PI of the ACT trial, and they are still going in kind of discussions with the FDA right now regarding approval. The company that is still going, so hopefully soon, but at least the European organization, the EMA, has approved it. So.
Okay, my second question, it is about the minor non-disabling stroke. You know, this is a broad spectrum sentences, and I think there's some sort of subjective. You might regard is there an objective criteria for the non-disabling stroke? The patient may have an ataxia or hemianopia. He will have an AS score of 4, but is minor, but still is a disabling stroke. Is there any kind of objective measurements, and let's say those kinds of strokes regard as a score of 4, but still they are disabling, and those are non-disabling? I haven't seen yet a clear cut on whether to regard this low NH score stroke as disabling or non-disabling stroke. Is there something to objective to designate or to differentiate between the two kind of strokes?
Yeah, so that's another excellent question, Dr. Hussam. I mean, to be honest with you, it is still subjective. However, I know from the trial, for example, the Tempo 2 trial was a TNK trial for non-disabling stroke symptoms, and the cutoff was either NIHSS less than 5. What they considered in that low category as disabling stroke patient who have complete hemianopia. So they are completely unable to see anything on the hemianopic side. Patients with aphasia or severe dysarthria that it's incomprehensible. They may reach an NIHSS of 4 or 3, but they may not be 5 or above. And then obviously the posterior circulation, as you mentioned, with ataxia, especially truncal ataxia, if someone cannot walk, then that is considered disabling stroke, although they may have NIHSS of 0 or 1 with mild kind of the appendicular, the extremity ataxia, the truncal ataxia is not captured. So at least I would think personally these would be ones, but as you mentioned, it's very subjective. If you receive it or if you get a pilot, for example, or someone who's a truck driver and they have complete hemianopia, this is clearly disabling. Even sometimes a partial hemianopia can prevent them from going back to being a pilot or driving. A school teacher who's unable to talk clearly. So all these things are subjective, but yeah, but at least I'd say personally, if it's less than 5 with complete hemianopia, with unable to walk because of ataxia or severe dysarthria, kind of aphasia, I think if it's complete aphasia or global aphasia, they will reach more than 5.
Okay, but some patients, I'm sure that you encounter some patients in your practice. In the first, let's say they presented at 120 minutes and 2 hours, so they have an score of 4 or 3. But it is not uncommon to see such patient to develop more severe stroke over the next hour. So aren't we miss such cases if we avoid them? And he will come with a score of 4. And after about half an hour, you will notice that this is score is still increasing. So how can we judge such cases?
Yeah, so this again depends on your practice observation, and I think as the management after once they arrive. So if someone comes the way you describe with NIHSS of 3, you do a CT angiogram, you see, let's say, an M3 occlusion or an M2 occlusion, for example, and the patient is doing well. Those patients, I think, will benefit from hemodynamic support, keeping them flat, IV fluid, whether you would start antiplatelet or not, especially if you want to watch them for sometimes before giving IV thrombolysis in case they worsen within the window. But these areas are still unsolved. I'm hoping that the papers that will give us some at least some guidance which patient population we should treat. And I think the patient with the more proximal occlusions are the ones that probably would treat. I would treat the ones with more distal occlusions, even if they worsen. They probably wouldn't reach an NIHSS of 7 or 8 because of the distal location. But these are areas that's still very subjective, and it is a case-by-case basis, Dr. Hassan.
Okay, thank you very much.
No, thank you. Excellent questions. Thank you.
Thank you, Dr. Hasham. Now, Dr. Aktham has raised a hand. Please, Dr. Aktham, welcome.
Hi, good evenings to you. Thank you for for a comprehensive presentation. Sorry if I am sitting in the dark. That's how it is in the. I am one of the stroke physicians. I'm not a neurologist. And you know, neurologists often not involved in stroke business. I have one question to you, and then two entrance in this lectures. One is I visited Iraq. I just came back 2 days now since I been back. In Iraq, we need to look to see actually data. Still, we are lacking of evidence of data, and the language of door to needle, door to scan. The onset to treatment. All this one it needs to be established. So we need a good involved in that one. If you have the data, the Ministry of Health will not ask the neurologists. They are very promising neurologists. I come across a fantastic group of neurologists. They are very, very promising there. So Health Minister will not come to you to have approval of Americans' guidance. You will set your guidance based on the data you have and the team workout. So that one, hopefully, we will see it in the future in Iraq practice. The second, TENECTEPLASE is not new. It is practice-based. So when you see Asian, they starting TENECTEPLASE. I attend in Singapore, the World Stroke Conference in Singapore. The Malaysians and the Chinese, they use TENECTEPLASE, but because it hasn't been support for a while of a wide trials in transatlantics, and we heading toward that. So TENECTEPLASE will come toward as a medical treatment in acute stroke. It might limited on such cases as you elaborate very nicely on your. So that will come to the light to see TENECTEPLASE as a treatment, our first choice of treatment. But the question here, who pay for that? So everybody knows TENECTEPLASE is more expensive than. If you tell us, Dr. Mohammed, in Canada who is funding these medications, it will be very useful also to people who is dealing with the Ministry of Health about the cost. If they want certain service, will be very clear to the cost, because that is very important. Particularly in Iraq, cost is very important in these particular things. Thank you very much. I'm very humbled to your presentation. Very nice presentation. Thank you very much.
Thank you very much for your comments. So, yeah, I mean, it is, I understand the limitations of the local practice and guidance, and data drives change, as you eloquently said. So I think starting to collect the data either retrospectively or hopefully even prospectively will help make the case, and not only for the need, but also the economical case for the use of IV thrombolysis. Patients who come with stroke, who don't get treatment with IV thrombolysis or thrombectomy, unfortunately, they end up longer hospital stay, they develop in-hospital infections, they cost the medical system directly and indirectly much more in comparison to the cost of the IV thrombolysis or even thrombectomy in patients with large vessel occlusion. So, and there is obviously precedence in many healthcare systems, not only in North America, in Europe, in East Asia, as you kindly said, and even from the MENA regions, from the Middle East and North African regions, that there are papers either describing the economic efficacy, the economic case for IV thrombolysis and thrombectomy, or the safety data in retrospect. The SITS most registry was kind of had some access, at least I know within few countries, Egypt and in the Saudi Arabia, UAE, for data collection. So that could be one platform that enable data collection within Iraq, inshallah, for just kind of capturing those patients. And as you said, these numbers are new, and if you cannot measure the process, you cannot improve it, and you don't know what you're dealing with. Currently, the cost of IV thrombolysis in most settings is covered by the government, by the Ministry of Health. That include, as far as I know, in Saudi Arabia and even in Egypt recently, the Ministry of Health and UAE and other countries in the region started to pay the Ministry of Health, just realizing that the cost of the IV thrombolytic or the thrombectomy procedure is actually much less in comparison to the medical care cost of someone with a major disabling stroke, who end up costing the medical system much more. And so I think there are a number of angles where this can be approached with the Iraqi Ministry of Health to discuss and see how that kind of can be made. But at least in North America, TENECTEPLASE is actually cheaper than Altiplase. It is still not a cheap medication, but it is relatively cheaper than Altiplase. And yeah, and I think it's hopefully if now the companies are going to make a smaller vial for stroke indication, like a 25 milligram vial, the current vials are 50 milligrams, or at least if the same vial can be, there is evidence that if the vial was mixed, that actually you could freeze the other 25 milligram and keep it for another patient that comes within few days, hopefully, or even longer. So there is some ways to kind of cut the cost and make it more efficient, but I think there is hopefully enough data and the possibility of collecting national data within Iraq, inshallah, for making the case for the Ministry of Health to support that.
Inshallah. Thank you.
Thank you. The other questions that I have here. Does TENECTEPLASE carry different adverse effect profile, angioedema, for example?
Compared to Altiplase, no. At least in the ACT trial, I know is the one that looked at these complications, and they were comparable, almost identical, which is expected, knowing the molecular structure of the two medication is very close. So the answer is no difference.
Okay. And can you elaborate more about the participation in ACT Global project for Iraqis?
Yeah, inshallah, I'll be happy as Dr. Kurda alluded. I'm more than happy to stay in touch with the network and come back and talk more in depth about ACT Global. But I'm more than happy also to set up a dedicated talk. Please reach me over emails, Dr. Mustafa, Dr. Kurda, Dr. Aktham, or Dr. Husam, anyone who's interested. I'm more than happy to arrange just a talk, just to explain the idea, what's happening. My passion and hope is to bring it to the MENA region, Middle East, and I've talked with a number of few colleagues, and it'll be a dream that comes true if, inshallah, we have at least one center in Iraq to take part in the trial, because this will help, inshallah, just make the evidence and create the culture for research and collecting data. And as long as there will be barriers, I have no doubt, but hopefully we can work them together, and through some funding from the trial will help kind of make the infrastructure for that trial and other trials.
Thank you all. There were no questions left.
Thank you very much, Dr. Baraa, Dr. Mohammed, all our speakers and guests. Thank you for waiting to the end of this meeting. Dr. Mohammed, do you have a final word to us?
Thank you very much, and hopefully this won't be the last time. And shukran
Inshallah, for sure.
kind of organizing and moderating. Thank you all. Thank you very much. Thanks, Dr. Kurda. Thanks, Dr. Mustafa.
Shukran jazilan. We remind you to follow us on social media with the network. We have accounts on YouTube channel, and we will upload all lectures on which. And also we have a Facebook account and an Instagram account. And finally, and lastly, we initiated our network on Twitter. We are open to hear from you and develop our work. So please, anyone, join our network if you don't yet. We are open to hear from you, to develop our work, and to looking forward to meet you on the next meeting. Have a good night, and have a spiritual times during Ramadan. Ramadan Kareem. Good night, everyone. Thank you.
Thank you. Bye-bye.